All right, welcome back to another PCBH Corner, and joined again by probably my favorite person in the realm of PCBH and just in the world is Deepu George. And Deepu, welcome back to another PCBH Corner. Really glad that you're here. And Deepu and I, we were talking about this a little bit before this PCBH Corner. Obviously, this is coming at a time where our nation is faced with another unfortunate shooting and tragedy. And I just want to express my gratitude, Deepu, for even having the conversation that we had before and potentially getting into that maybe a little bit at the end. But I even like how you said, I think my mind's trying to almost replicate what you just said. Do you want to share that about that acknowledgement piece, even just right now?
Sure. Yeah, I'd be happy to. I was sharing with a group of our resident leaders yesterday. We had a little thing for them, and obviously we want to be sensitive to the context that we all swim in, right? Like, how can we move on without acknowledging something, no matter when and where you may be watching this video. We're on May 26th now. 2 days ago, there was a senseless act of violence in Uvalde, Texas, where 19 kids and 2 teachers were murdered. And where my mind went and my heart went yesterday was just to acknowledge. I'm honestly not sure what we should be feeling, what the right feelings are. I feel like it'll be around some sense of sadness, anger, rage, frustration, a sense of hopelessness, and all of those feelings feel like okay, those, just acknowledging that and letting it be there. What I did with them, and perhaps what we can do now for a few seconds to a minute, is whatever helps you connect to the deeper humanity within you. That's what I'm wanting to invite you to do for the next few seconds, whether it's through your faith, whether it's through sending kind wishes to people and their well-being. No matter when you watch this, those families are marked forever. So even if we hold them in our thoughts for a few minutes, I still think it makes sense. So I'll just do that for a few seconds. All right. Thanks for doing that, man.
It's such an interesting experience. And we talked about this with the first PCBH Corner, Deepu. I just have such gratitude for you because of this ability of, just being able to help people connect to their humanity, and even through a virtual format through Zoom. And I think that's the common thing that most people will say when they get to interact with Deepu. And I said the same thing at the first PCBH Corner that we did with you, and hopefully inviting people, and this might be not good for you, but at CFHA, or if you get a chance to talk with Deepu just in person, please take advantage of it, because I think there's just a sense of, I don't know, connecting to that humanity, connecting to that spirituality that just naturally occurs outside of like what we just did here, which was obviously an intentional moment to create. But I don't know, your existence always just does a good job, I think, of bringing people back centered and connecting. So my gratitude.
That's very kind. That's too generous. I appreciate
no, not at all. Not at all. In my mind goes, a couple different ways leading off in this. And Deepu and I, we tried to come up with maybe some questions at the beginning that we were going to go through. I'm going to go totally off script here for it. So my mind went two ways. One, you were talking obviously about this discussion within the residency that you were having. And I don't think we talked about this the first time. Now my mind's going to beat me up about like, are we repeating the conversation that we had? What do you see? And this is probably a broad question. I think you always do good with broad questions, and we can narrow it down if needed. What have you valued about this interaction that you've been able to have within residencies, coming from this, a PCBH perspective, or just a behavioral health, or just a humanity perspective? What have you appreciated about working with medical residents? And then maybe even more specifically, after that, what do you hope to do when you're working with residents? Because at CFHA, we have a lot of people that I think do both PCBH and work in residencies. And I think they go very well together. Oftentimes, I don't think we talk about the working with residents in a lot of ways. So what do you appreciate about that experience? And then also anything that you really try to impress upon the residents, really inundate them with, anything that your mind goes to?
Yeah, I think that's a pretty grounding question for me, because yesterday we were kind of like, this was like our first time. We were a relatively young institution, and so we have this entire initiative that we're doing around resilience this year, and so that's like, it was kind of planted in a conversation, and then it became kind of my co-responsibility with some other people to put it together.
I want to pause you real quick. Isn't that so true about what just naturally things get gravitated towards? It's like, oh yeah, and suddenly I'm in charge of this right now. So.
Well, I was like, I'm partly to blame for this, but I was standing there yesterday, and I honestly have profound gratitude every time it does come to my awareness. Is just the fact that this is what I get to do, right? Like, and just to be in the presence of these kids and and their training. I mean, I say kids like I'm an old person, but just being part of their lives in this meaningful way, and being able to help them think about things that they typically won't think about. I find it very grounding, because I think I tell the story a couple of places where, in 2013, I was just dying to get into integrated care, and I just had zero clue and zero options in front of me. I had this one internship set up for me, and it kind of fell through, but then it kind of came back on again. But so, I went through like a lot of heart sink moments to get into integrated care and PCBH world. So I'm very grateful for the opportunity to do so. I have learned a lot about how to teach, how to be, and how to shift the ways around learning with residency education versus what you would typically get in a PhD program, right? I mean, we kind of go through this, at least I was in a traditional MFT kind of a program where there's like just a lot of reading, reflection, discussion, debate, and then of course you do some clinical work with that. And that mode doesn't click on with the residents, right? Like, they're not going to read, they're not going to be curious about theory and all of that kind of stuff. So one is just really watching our physician attending faculty kind of do their teaching, and kind of understanding the role of clinical teaching, which have really shifted all of our rotations in PCBH2. All of that has been very meaningful. I do remember just sitting down with one of our graduating classes, and kind of just having this open dialogue about, tell us like where we're not reaching you. Like, how are we failing you? Like, what about our didactics is not working? What about like the rotation is not working, right? And that kind of became like a big data gathering process for us. And we really shifted all of our assessments and our rotation schedule, and it's very clinical. They're in clinic with us now, so we created all of that. When I do sit with residents, one is I try to think about, what are they not going to get from other places. So one is, who's going to show them that it's okay to struggle, right? And I'm assuming just by the way medical culture and just culture in general is conditioned, they're not going to kind of get a lot of models of it's okay to struggle, it's okay to stress. And you didn't get that right. Yeah, that makes sense. I didn't get it right either, right? Like, so just kind of giving that sense of a perspective. I remember one of my residents a long time ago talked about how stressed she was and how she was feeling behind and felt inadequate and all of that. And she was telling me all of this, like while we were in clinic, and kind of winding down for the day. And I was like in a very kind of like an unscheduled space in my life with all the projects and all the craziness that was like on my desk. And so today my room is pretty clean, but usually my office is a good metaphor for where my mind is, right? And so I'll have like papers all over. I'll have like unfinished coffee cups, these things all over the place. So I said, why don't you come with me to my office? And then, and my office was a mess, right? So I walked into my office, and I said, I just want you to look around, and I just want you to know that's a pretty clear reflection of where my mind is and how I'm feeling. And so, I have nothing wise to say to you other than you're in residency and this makes sense, and so one is like giving them that experience. The other reason I fell in love with ACT was also the theoretical easiness, or like the parsimony that exists within the ACT framework or the FACT framework, and kind of helping explain things to patients and residents. That's why I fell in love with ACT even more, right, as I was kind of beginning to use it. So I do try to give them that contextual perspective in conversations, whether it's helping them making sense of symptoms and kind of letting them know that it's clearly not abnormal for them to feel this way based on everything that we just gathered, the history that we just saw. Also then kind of like driving them away from maybe simplistic interventions when they are on rotation with us, and kind of when I'm like observing with them. If I see them going into like a space of avoidance in the visit, and so I may kind of jump in and kind of help them steer it another way, where we are staying present with emotions and other things that may be coming up, and at the same time teaching them how to receive the information, stay with it, and at the same time teaching the patient to sort their experiences in the moment, right? Like, and so I try to do those kind of things with residents, like imprint upon them that emotions are difficult, and they are honorable, and it's okay when they show up in the room, and then saying, flipping it around, saying, what were you feeling in that moment? How did you handle it? Now, whether it's a medical visit or a VHC visit or whatever it may be, right? It's just really helping them think about, where are you in the process, which I think is obviously something that they may not get in every rotation. So those are the places my mind goes.
Dude, so many different things in my mind wants to come out of. This is why I love these conversations with you. And the first thing that you said, and I hope to really, well, I'll say it a different way. My mind really goes to the importance of being able to recognize the work that we get to do if you are working in a behavior scientist role, if you are working with the residents. Because the first thing that you said, I couldn't agree more with. And this idea of like just acknowledging what you get to do every day. You get to, it really is, and especially when you think about what family med providers, like how many people they're probably going to see throughout their career. And the impact that could have. And I think that's the thing, we talk about regularly, how much our minds just habituate to things so quickly, and we lose sight of that a lot. It's like, oh my gosh. And I had a similar experience to you, like, as you said, like wanting to get into integrated care and thinking back to that, and now looking at where you're at right now, and it's like, oh my gosh, like this is this is incredible that I'm getting to do this. And I'm also having that sense, I want to acknowledge the moment right now as you were talking, I was like, how freaking cool is this that we get to do PCBH corners? I get to talk to Deepu, and we get to, I think those are the things, like to continue to bring back to that moment. It's just very, very struck. I also absolutely loved the two things that you were saying about, one, not trying to take what we as maybe behavioral health providers and how we were trained and try to force that into how residents, right? I cracked up inside when you said about readings, right? So I'll tell this story real quick, and I'd love to know where your mind goes. We used to have these readings that residents had to do, and lo and behold, no one would do them, right? Like no one would do them. So then we were like, oh well, you're gonna write an essay on these readings, and it's like everybody hated it. I hated it because it's like, I don't want to read these essays. Like,
I know.
right? So in inherent within that, how I love that you said, like, continuously asking for feedback and being curious about, like, what could we be doing better? And I think that's a big thing. I just really appreciated that you said that. I don't know if your mind goes anywhere there.
I think it was also like, and maybe it's like taking too much responsibility, but part of our question was, where have we failed in reaching you, right? Like, like how did we miss? Because I'll tell you, our didactics, it was like a high intensity schedule. It was kind of inherited from a previous residency in North Carolina, and we kind of, like, when we started here, a lot of the framework came from there. And so it was like every Friday it was like 2 hours of behavioral science didactics, right? And so,
which sounds awesome, which sounds great, right?
Which is great. But man, that means I was in the first 2 years that I was here, I was doing like 40 something lectures a year. And then it was for the first years, and then they would kind of have the second and third years kind of go off to clinic. And so it was just really the intern class that I was dealing with. And then the other thing I called kind of our colleagues on it, it's like, like it's less integrated because like behavioral science first years and everybody else goes away. I was like we're kind of creating a split where it doesn't need to be. So now, like, what we do now is like our lectures are integrated within the regular didactics. We have 2 times a month that we go, and usually one of the lectures we try to do concordant with whatever the topic of the month is, and then another one where we may focus on something else, right? And again, it's just really going down to typically, so we now have cases that we use and make them think through the cases and what they may say in a case, all of those kind of things. So we've definitely grown, like, from the time that we came in.
And that relates to the other thing that you were saying that I loved about when you were talking with that resident that was feeling overwhelmed, kind of out of control, and you bringing her in to your office and being like, yo, like, this is this is my experience right now. We're here together, like these experiential things. Right. That I think what I found, I couldn't agree more, are so much more valuable, especially talking to residents and maybe other professionals that aren't rooted in like the behavioral sciences, and they're just getting this training, like these experiential things that we can do, and the power of them to like show the topics and the concepts that we're trying to share. I think could be really great versus just like giving them a reading. I think at the beginning, like, we were giving them readings on like functional contextualism. and again, a cool idea that gets us excited about it. But the reality is, it's like, I struggle reading stuff on functional contextualism, and then expecting our residents to pick that up. It's these experiences, I think, that can really shape that. That was really cool. For sure. Yeah. And now when we do something in clinic, and then residents are like, oh, like, what happened in there? How did you do that? And I was like, oh, so you want to learn more? Now here's a reading, right? Now let's link you up with the reading that's going to connect the dots for you. Essentially, the context now is there. You've created the context where it's like the behavior of actually doing the reading makes sense to actually do, versus this. Absolutely. And my mind goes, is there any advice? Because I'm sure you get these emails a lot. I know I do at times, of people, because the behavioral scientist, it's a required thing for family medicine residency. So there's a lot of positions out there for it. And ultimately, and all grace and compassion to residencies, I mean, a lot of residencies are just trying to survive and focus on their training. A lot of times it turns into, hey, we're just hiring a mental health provider to come in and develop this curriculum and just go out there and be somebody, right? Like a lot of times what integrated care is, a lot of times where it's just like systems being like, hey, we're going to hire someone, they'll know what to do. And it's like, it doesn't work that way in a lot of ways. So is there any advice that you would give to maybe like a new behavioral scientist that hasn't had a lot of training and exposure to residencies, on where you would suggest to even start a curriculum on behavioral scientists?
I think one is to kind of like locate yourself and what is it that you really see yourself doing, right? Because I think that the integration of behavioral science faculty into family medicine residency is a long tradition in family medicine. And at the same time, I feel like it's an evolving tradition, right? Because the evolution is there was the sense of really the behavioral scientists being rooted in kind of deep psychotherapy traditions and
100%.
Kind of a resource perhaps at times for the residents themselves, and kind of being like the safe zone kind of mentality or like that perspective, and then being able to show them like maybe what the psychotherapy looked like, and attend these rotations where they're sitting in with the scientists and doing therapy and all of those things. And I think that model, I think, functioned really well where healthcare was like probably a couple of decades ago, right? Like 10, 20 years ago, that may have still continued to work. Whereas I feel like we're in a shift in how we're beginning to think about the role of behavioral health in primary care, the role of behavioral health in chronic health or chronic disease and health management, and the role of behavioral health in increasing access, et cetera, right? And to me, for a new behavioral scientist, is to kind of really locate yourself in where do you want to be. I'm going to argue that they ought to be and kind of in the front lines, in the trenches mentality, where we're kind of not shy to see patients, not shy to be in clinic, and but then also I always get sensitive here, and I'm mindful of it, about what did they pawn off to the behavioral science team versus what do they keep, right? And so we have this constant thing of like pushing back and saying, and now I can do that after like 6 or 7 years in the job, right? Like I definitely wasn't doing that like before. I have some seniority here now. We've been here for a while, but it's just really saying, like, how do we why is certain things given to the behavioral science faculty versus just the faculty, right? Like, why is there a distinction there? I think there's a conversation that we're gonna probably do at some point. They want like a session on feedback, right? Well, like behavioral science folks are not the only ones giving feedback. Everybody has to have that skill set, right? So we want to figure out ways to co-lead that instead of it just being like a this thing, the whole idea and notion behind wellness. Granted that our team is going to do a lot more reading and kind of like keep our eyes to the literature and kind of pick up what's going on and kind of bring in these non-stigmatizing frameworks to wellness and kind of bringing like a contextual framework to wellness. But at the same time, it's the wellness thing, it's not our drug to push, right? Like it's something that everybody needs to kind of own and move forward with, because we can't push it. It won't make sense.
Deepu,
So,
you're setting these things up so perfect, because I could not agree more. And I've always struggled with this wellness, and we pushed back on this. And similar to what you said about like feedback, within the wellness category and context, and I've had really candid conversations with our faculty and our residents about this, is that when wellness is only done by the behavioral health team, it's just a behavioral health thing, right?
Yeah.
And the irony
Mhm.
about it is like I have no idea what it's like to be a resident and a
Right.
medical provider, and I could see it from the outside, and it seems absolutely terrible at times as far as the demands and the
Yeah, yeah.
responsibilities and stuff like that. And so for me to come in and talk about wellness, it's like there's a huge gap of kind of experience and knowledge. Not to say that we can't give,
Right.
suggestions and ideas and stuff like that, but for it to actually be something that, as you said, is uptaken, it's something that the whole faculty it needs to be about. It's something
Yeah.
that this whole understanding needs to be about, for sure.
Oh, absolutely. Yeah. And, so we've been kind of like, I'd like to say we've been in the lab for a couple of years and like thinking through wellness and other things. And we are rolling out this initiative now called Fortify Resilience that are kind of like for the residents and fellows here. And a couple of things that we've relied on, right? So one is we kind of like took uh, self-management principles
Hmm.
to think about wellness, right? So we, through the help of a person named Alyssa Gatto, who was like a Virginia Tech grad student who worked with us, she introduced us
Yes.
to measurement feedback systems like the MFS idea, which is fancy way of saying we're going to give you data on your performance or whatever, whether it's your A1C, blood pressure, et cetera. And as you receive the data, can you then put some new behaviors in place to see how it changes the data, right? So it's like basically self-management, but you have like continuous monitoring and feedback on how you're doing, but just the idea that hopefully that is gonna change your performance over time, right?
Hmm.
Um, so we kind of ran with that idea. We kind of settled on this notion that well-being is well-being, whether it's high or low. So
Hmm.
we don't want to really get stuck on positive well-being or negative well-being. We really want to just say your well-being needs to be monitored. And it may
Hmm.
be that just by design of being a resident, by design of being a fellow, there will be moments and months where it's dipping. Like if you're kind of going through residency without that, I mean, one, great, two, maybe something's wrong, right? Like,
Correct. That would be
like
weird. That would be weird, but
it would
yes.
be weird if you didn't struggle a bit, personally, professionally, in some way, right? And so then we kind of ran with that idea, and then we then looked at like a lot of the stuff out there, and like so there's like the well-being index and other things, and we noticed that it measures like a lot of pathology, like it really looks at like anxiety, depression, and all of that. And we were kind of framing it as well-being. Whereas we started then thinking about what are the drivers of like in our life that may actually perpetuate a negative state of well-being, right? So we started looking at self-compassion, quality of life, and then just general sense of their own self-assessment of stress in their love, work, play, health, financial areas, right? And so we're working on a mobile application that's going to kind of do this, right? And so like we're working with now we have funding to actually go full on with this thing, right? So we're in the process of doing that. The other thing that we said about well-being was, so again, we're not rolling this out. We're obviously in the background, like writing the playbook here, but like our DIO is the PI. She works with our team to kind of push this out. We kind of also recognize that well-being is an individual thing as much as it is a group thing. And so how does the group get feedback on their overall well-being? So one of the mechanisms, again, this all, either it'll work or it won't work. So we're kind of curious about what it will do. What we want to do is as individual users are engaging in this app to kind of monitor their well-being, what we want to do every quarter is give group level well-being performance to the group and kind of
Uh,
say, here's where this program in this location is doing. And we've also developed like a wellness champions toolkit, which is like helping the program develop skills to process the data and make changes, right? So we have an entire set that's focused on, are you functioning from a prevention mindset or are you functioning from a promotion mindset, right? Because I think we approach things, so those who are prevention mindset may want to like prevent certain things from happening, Whereas if you're promoting, then you may want to add things to kind of improve your well-being. So that kind of sets up how the committees work. So we're just kind of putting it back in their hands and kind of saying, your well-being is something that you want to monitor, and we want you to come back to it as often as you can. Hopefully the app will like begin to be some enough data gathered so that there's some machine learning and artificial intelligence that kicks in later, so that the recommendations that we give you or the app gives you is more customized. And of course, we're going to pull from mindfulness science and ACT and all of that things to kind of make those things work. But yeah, that's where like what we've been doing with, well, at least that's what we're thinking. We're in the lab, we're pushing these ideas, we're working on the design and all of that right now.
One of the questions that we have, what are you working on? So this actually, this actually works out perfectly. And Deepu, the thing that I love so much about this conversation, and a lot of different things on my mind just get so excited about, the one that I think is so powerful and it's so needed, not only in residency, but just throughout our existence, is this recognition of that even changing the word from wellness to resiliency. I know people are getting, there's conversations about, is resiliency the right word? I think these words are always going to rotate and evolve as we go through. But the importance of acknowledging the context that you're in. And one of the exercises that we do with our residents when they start with R1s is, I ask them a question, what makes a human being healthy, right? Like what makes a human being well? And we put all these things on the whiteboard. I think we maybe have talked about this even before, that, usually drill down to like 5 things, like diet, exercise, sleep, social connection, and like a purpose, a meaning that you have. So then we go through, it's like, okay, so when you're on your inpatient hospital rotation, how much sleep are you getting? Are you eating good foods? Are you exercising? Are you spending time with family? Like, do you feel connected to this meaning? And then this awareness, it's like, that's not a fault of yours. Like, this is the context that is coming up. So that is going to probably cause a struggle. And there's not a wrong thing with that. I mean, we can debate about, should they be working that many hours and all that stuff. I mean, that stuff is debatable. It just is, it's a tough time. Right. And as we always said, what happens so beautifully and contextually when we normalize and contextualize a situation, compassion naturally grows. Because we don't fight something that is supposed to be there, right? Like we don't fight feeling this way if it's not. And I love that approach of just this, because I think so often, and I'll get off my soapbox about this, but we even do this with mindfulness, right? Like we were like, hey, you know what? You're burned out or you're not well, practice mindfulness, right? And it's like best thing. And it's like, that's not how it works. That's not the purpose of it. And how almost decontextualized and as also like invalidating that is, that it's like the reason why you're feeling this way is because you're lacking a skill or you're lacking something. And not to say we can't work on skills, but it's like, we're not acknowledging this context that we're in right now.
Yeah. And I think the other thing is with the whole resiliency well-being, I think part of the danger is the pressure to be positive, which I can't, that does irk me a lot when I hear anything that has like to be like about think positive thoughts or whatever it may be, right? Like all these, pop psych stuff that kind of comes up, right? And so I think that's another message that I feel like we should do to counter, because I think it's a disservice in the long run.
Now, Bridget just actually slid in a note. The podcast is starting. I'm assuming, do you have to jump over to the podcast right now?
I do, yeah. I do.
Yeah. Okay. So we won't even, I was going to say last thing, what are you looking forward to CFHA? Can you say that in 10 seconds? What are you looking forward to CFHA?
The people with connections, stories, and like a huge dose of meaning and purpose that I've been missing for like 2 years.
Amen. Hey, my gratitude again, man. Thanks, it is so good to see you. Thank you for this, as always, this riveting conversation. And then also, as you always do, just so incredibly well, connecting to our humanity. So my gratitude, get over to the podcast and we'll talk again soon.
Yeah. Thank you so much, man. I'll talk to you soon.
All right, man.
All right. Bye.